Hello and welcome to ADHD Mums. In this podcast, we tackle the tough, often unspoken realities of motherhood, neurodiversity, and mental health. Hello and welcome to ADHD Mums. Today we have one of the episodes that has been very highly anticipated, if not by anyone else but by me, and that is with Dr. Lara Briden. How are you, Lara?
I'm good, thanks. How are you, Jane?
I'm good. I am very excited. We are in the hormone mini series, which has been very much anticipated. And I was hoping if there was one person that I wanted to get on, it was absolutely you. And then I got you onto HRT, ADHD, and perimenopause, which is what we're talking about today, which is very exciting. If there is anybody who is unfamiliar with your work, would you mind giving a really brief background about who you are and what brought you into this space?
Yeah, absolutely. So I'm a naturopathic doctor. I'm Canadian, but I've lived down under a long time. I lived in Australia for about 15 years and now New Zealand for 10 years. And my work has been all around women's health. So period problems, hormone problems, thyroid as well as a very common women's health condition, and using natural treatments. So using a combination of nutrition, herbal medicine, supplements, and body identical hormone therapy, which I'll just say at the outset is we're living in a great time right now, because what used to be alternative, body identical or bioidentical, is now the conventional hormone therapy, which I thought it would happen faster than this, but finally happened.
Oh, fantastic. Let's jump right in because there are so many people that are interested in this area. I did a couple of solo episodes last year about PMS and PMDD and how a lot of us talk about how that affects us with our neurodiversity. But then I was getting a lot of DMs, and I still continue to get that, around what would be PMS, PMDD, and then what would be the perimenopausal phase. Like, how do you know which is which?
There's not a clear demarcation. I'm sure you know, intensifying premenstrual mood symptoms are one of the symptoms of perimenopause. There's a lot of different descriptions of perimenopause floating out there. I tend to use a narrow definition. It's when the ovulation starts to become less regular and not making as much progesterone, basically, with the cycles. In the early phases of perimenopause, you can still be making lots of estrogen, and we can talk about that a little bit. But yeah, this will often, one of the classic symptoms, as well as night sweats and weight gain and things like that, will be an intensifying of premenstrual mood symptoms. So it's a sliding scale. Like, at what point, if premenstrual mood symptoms are intensifying and a woman is over the age of 40 or even over the age of 37, 38, and there are, especially if anyone who's tracking their cycles could really tell if there's signs that the luteal phase is shorter or less robust with the luteal phase, that would all be evidence that it's perimenopause, as long as other things have been ruled out. So perimenopause is also a diagnosis of exclusion. You also have to rule out, is there Hashimoto's thyroid disease flaring up? I just had to give thyroid a second mention because it's such a common condition, especially in women in our 40s.
Perfect. Okay. And then there's the whole question around ADHD and then brain fog, perimenopause. It's like the perfect storm, isn't it? Because sometimes I think, oh, it's my ADHD. And then I think, I wonder if I'm in some kind of brain fog, perimenopause. Does it look the same?
So brain fog is a symptom, obviously. It's not a condition. And the naturopathic approach, I'm not sure how many other naturopaths you've had on your podcast, but obviously one of our big things is to, and I've written about this quite extensively actually, is for certain conditions to go beyond the label and dig down to what's actually happening for the individual. I treat the individuals. So brain fog, of course, as you say, it can be a symptom of ADHD, it can be a symptom of perimenopause, but that doesn't mean that it's not a symptom of something else. So for someone who just happens to be 42 and have been given an ADHD diagnosis or label at some point, it doesn't rule out that their brain fog could be from gut or B12 deficiency or thyroid or sleep apnea. I just actually recently had a patient who I've worked with her for a few appointments, and we're just trying to troubleshooting a few things. Brain fog was her main thing, brain fog in the morning. I kind of finally actually asked her straight out about sleep apnea, if your listeners know what that is. And she's like, oh yeah, I was diagnosed with that as well, but I don't currently use my sleep apnea machine. I'm like, well, that could explain a lot. If you're trying to keep all treatment focused on ADHD or perimenopause, you don't want to miss the opportunity to treat other major drivers, especially a symptom like brain fog, which is so nebulous and certainly not unique to either ADHD or perimenopause. It's a very common symptom. And I'll just say again, partly through my naturopathic lens, it can be often gut related. Food sensitivities, also intestinal permeability affects brain fog quite a lot. And then you have a whole role of the autonomic nervous system. Polyvagal is all to do with the autonomic nervous system. So the autonomic nervous system is our unconscious nervous system. It's the thing that controls breathing and heart rate and digestion and blood sugar. It actually has a huge impact. Like it's huge, especially in women, even more so than men, regulator of blood sugar. It's also a regulator of all the other hormones. So polyvagal is around sympathetic, parasympathetic. Like the ADHD picture looks very much like that kind of freeze. I think it's called the ventral vagal response. There's like a particular kind of autonomic response. To me, looks quite a lot like ADHD. It's often, and it's quite common in women. So there's two different parts of the vagus nerve. The dorsal vagal is the freeze response. This like just complete kind of overwhelm, like cannot connect with the next actions to do. It's just this, it's very much a brain fog situation. And everyone can be in that response at some point, but some people just, that's kind of their default nervous system response with stress. And it'd be the time when you just have to you're so overwhelmed, you just have to sit there and scroll your phone. And it's super interesting. And I think seeing things through that sort of lens and different nervous system types, I kind of like it because it's not as pathologizing. It's sort of just acknowledging there are different people have differently wired nervous systems. Some people tend to, I'm more like sympathetic fight or I'm actually the flight. So I get the like upper shoulder crunching and get a bit anxious around with stress. That's a particular wiring. And then you get the freeze response, and just different people respond to stress, which can then be affected by trauma and things like that. Then of course, hormones will start to intersect and overlap with all of that. What's happening with the nervous system. Neuroendocrine is the word, that intersection between nervous system and hormonal system. Yeah.
You've made some really interesting points. We just did a mini series into schools and we talked about a neurodivergent student having that fight, flight, freeze. And it's very similar to what you talked about. It's just through a mum lens. I think that's a really interesting point. I'll have to have a look at that actually.
Yeah. The freeze response wouldn't be like unique to people with ADHD. Like it would be more broadly something that it seems to overlap a lot in the descriptions. We always, like every generation or half generation, we have a new term or narrative to describe what's going on. Like 15 years ago, there was a lot about hypoglycemia and the kind of brain fog and just crashing kind of freeze response you can get from drops in blood sugar, which is happening with a lot of this as well. It's just we're not calling that, like, yeah, what narrative you want to put around some of these symptoms. I guess I'm just inviting people to do what I love to do, which is troubleshoot the situation. And like back to my patient who finally I was like, oh, bingo. Okay, sleep apnea is driving some of this, and it's driving the brain fog and the distraction and the nervous system dysregulation in her case. But it's going to be so many different ways and things that can be fixed, right? So the kind of troubleshooting I like to do with patients and that I write about in my books is obviously troubleshooting things that can be fixed. My favorite, in my latest book, I talk about the easy and highly effective interventions. I talk about different obstacles to health in my last book. And you want to start with, in your journey back to health, finding those obstacles that are simple, high priority, and easy to fix. And in my patient's case, that would be wearing her sleep apnea machine. Sometimes that would be other examples of high priority things that can really move the needle on brain and brain fog and anxiety and things like that. Are obviously correcting nutritional deficiencies, whether that's iron is a big one for women in their 40s. Iron is huge, right? Because women with heavy periods are walking around. Being in a low iron state is instant brain fog. It's really difficult to be in that state. And also correcting iron deficiency might also mean addressing heavy periods, which is something I've written a lot about. Other kind of high priority, fairly simple fixes would be, I'll just go back to food sensitivities, gut things. Of course, as a naturopath, we're always like, it often comes back to the gut. And that's just because it can work so beautifully. If there's a gut problem and then you address that, not only does the gut feel better, but suddenly the brain fog lifts and the periods get better and just everything flows from that.
This is really interesting. So when we talk about how you may see a presentation of a neurodivergent woman, and a lot of us have got chronic health things, and it can be quite a bit, it feels a bit messy really, because when someone says, what's your medical history? You're like, oh yeah, I'm completely fine. And then you list about 1,000 different things. So is there any red flag things that you would look for when you're hearing a lot of this mishmash of chronic health?
Yeah, like my clinician brain would be running through a lot of what I've just talked about, looking for straight away with brain fog. I'll be like, okay, are you B12 or iron deficient? What's your sleep quality like? That's how I finally got onto with my one patient. I missed it for a couple of consults, but realized her sleep apnea quality is deeply impaired. But the other reason sleep can be a problem, and this is what the approach I've tried to take in my book, is troubleshooting, right? So you've got these symptoms. What are the different things these symptoms can mean? And another one I want to bring into the hormonal conversation and brain fog and ADHD to some extent is have the role of histamine, which intersects with not only food sensitivities, but especially as we described, people got a whole list of health problems like migraines and gut problems and rashes and joint inflammation. And that can be part of a mast cell activation or histamine response, which, if you want a little bit of biochemistry, the interesting connection with ADHD is that there's a histamine receptor in the brain that, when it's activated by histamine, which is a neurotransmitter, which is very agitating neurotransmitter, one of the downstream effects of that histamine activation in the brain is reduced dopamine production, reduced GABA and reduced dopamine. So you can see how that knocks on. And the reason it's important hormonally is high estrogen increases histamine. So a lot of what women describe, and not so much in your space, but in the natural medicine space, has been a lot of talk of estrogen dominance and kind of estrogen dominant symptoms. Those would be like rashes, fluid retention, headaches, brain fog, agitation, and almost like bordering on kind of rage, like a really strong irritability. That is something that's been characterized, again, back to the kind of what narrative or label do we put on things, as estrogen dominant. But through my lens, looking at the biochemistry of that and the biology of that, I think a lot of that kind of picture is a histamine response. So it's being aggravated by high estrogen compared to lower progesterone for sure. And so coming at it hormonally with some progesterone support, we can get into that, or taking steps to lower estrogen in some cases can help. But you can also just take steps to try to lower histamine. And that's where gut health comes in. Gut's a huge player in that. That's where avoiding alcohol comes in, because alcohol, in most people know this, right? Like a lot of, especially the really histamine reactive people, they'll be like, I had a glass of red wine and then I just like super irritable, couldn't sleep, night sweats, maybe even fluid retention, migraines. That's it. A histamine response, not to the alcohol, but there's actually histamine, amines or histamines in red wine. So some of your listeners will know what this is, because this is quite a common experience. And that kind of approach. And all of it can work alongside an ADHD diagnosis. I just feel like through my functional biology kind of lens, there's only so much you can do with the ADHD label itself. Like, you sort of always have to look beyond that and deeper than that and look at some of the physiology that might be driving those symptoms.
Excellent. Okay. There's quite a number of people in the Facebook group that have gone and got all sorts of testing done, like the Dutch test, which is quite expensive, multiple blood tests. Then they come up as air quote normal. And then it's actually really disappointing, because you're hoping something will come up, because then there might be something that you can do. When you get that, oh, it's normal test result back, and then you're sent on your way, but you still are feeling pretty awful. Is there any test that can actually identify perimenopause? Is that a thing, or you just can't tell?
Nope. It's not a thing. There's no test that can measure perimenopause. So perimenopause is a thing. Testing for it is not a thing. So perimenopause is for sure real, the transition state. It's second puberty, as I write about in my perimenopause book, Hormone Repair Manual. But there's no blood test or urine test. I don't use Dutch testing myself. I do a lot of blood testing for different things, but I rarely measure estrogen and progesterone, because it truly fluctuates so much. Like, a one data point on those hormones is not very useful, except for in maybe certain contexts, if you're just trying to confirm ovulation or something like that. It doesn't tell you very much. I guess certain with Dutch testing, they do it across the cycle, which is obviously a little more useful. You can start to get a pattern of what it's doing, but you may still, for example, with any kind of estrogen testing, you may actually miss the massive spikes in estrogen. During perimenopause, estrogen spikes up to 3 times higher than normal. And when you think about that intersecting with what I talked about, like the mast cell or histamine response, and also estrogen itself is very stimulating in both a good way and a bad way, especially from an ADHD perspective. Like, the higher estrogen goes, the farther it has to fall. And that falling is normal, because estrogen in a perfectly normal, healthy menstrual cycle, especially in young women, estrogen goes very low at the end of the cycle. Just before the period, it drops down to menopausal levels. That's totally normal. I've had patients say, oh, my estrogen was tested on like day 2 and it's menopausal levels. I'm like, well, that's perfect. That's like where your estrogen is supposed to be. It's an example of why testing is limited use for estrogen and progesterone. But the higher estrogen goes, the farther it has to fall. The best way to detect that is with symptoms. I was just talking with my colleague, endocrinology professor Geraldine Pryor, last week. Actually, she came on and did a live webinar with me and some colleagues. And she reminded me, this is in my book already, but it was just a good test, a really classic test. If you're wondering, is my estrogen high or low? A simple physical test for higher than normal estrogen is when you push in with your palm, like your hand, straight in on your breasts, like from the front. And if that elicits pain, that's a pretty clear sign that estrogen has been high. Another sign of high estrogen would be heavy periods. which are classic during those early phases of perimenopause. So in answer to your question, no, there's no blood test. The diagnosis of perimenopause, like I said, is from context. So I'm a woman, at least, unless there's a early menopause situation, that's a whole different thing. But for a normally timed perimenopause, anytime from a woman's late 30s into her 40s, mid 40s, late 40s, she starts to experience symptoms, like I said at the beginning, increased premenstrual mood symptoms, breast pain, increased frequency of migraines. Professor Geraldine Pryor, who I just mentioned, has a list of 9 symptoms that I included in my book. And she says if you have at least 3 of those 9, it's weight gain, night sweats, sleep problems, things like that. If you have at least 3 of the 9 and you're the right age and other explanations have been ruled out, then it's perimenopause. And the other way to confirm, like absolutely scientifically, would be charting cycles. So I don't know how many of your listeners are cycle charters, that their own special group of people. I love them, the fertility awareness people. So those would be women who chart their cycles with temperatures and cervical fluid, know if exactly, it's called body literacy, knowing exactly if and when you ovulate and how long that post-ovulatory luteal phase is and what it looks like. It sounds complicated, but a lot of it you can do digitally now. And so if anyone listening is doing that, then what you're looking for in perimenopause is a shortening of the luteal phase, not the proper like 12 to 14 days, but 7-day luteal sometimes. And then obviously more cycles where you have no luteal phase at all, because it's entirely possible to have a period, even a somewhat regular period, and not have ovulated. More and more cycles like that is a sign of perimenopause as well. So that all is about what I've written and what endocrinology professor Geraldine Pryor always says is perimenopause is almost by definition when progesterone starts to drop away, our second hormone, progesterone. So hopefully that's starting to paint a picture. I'm making it sound a bit more complicated than it is. Like my theme with all my books is women's health is not as mysterious or complicated as we've been led to believe. There's ways to figure it out.
Oh, no, I actually think that's brilliant, because a lot of the experience that the listeners have is the question, am I in perimenopause? They go to a GP, the GP gives them a blood test and it comes back normal. And then they're told it's not that, given an antidepressant and sent on their way, and they feel insane. There is something innately wrong with me because it's not perimenopause, but I'm having all of these symptoms.
If someone's 45 and having new mental health symptoms, and especially sleep disturbance or night sweats, it's perimenopause, unless it's thyroid or something else really obvious. Like the test their doctor might be trying to do is a test called FSH, which is not a test for perimenopause. It's a test for early menopause. It's related, but it's not. So almost by definition, honestly, by like 45, you're in perimenopause, unless someone's having a much later perimenopause, which is possible. There's quite a wide range of normal. So some women are, nothing really starts up until their late 40s. And then those are the women who might keep cycling until their late 50s. But for the vast majority of us, by the time you're in your mid to late 40s, by definition, it's perimenopause. To be clear, though, not everyone has a symptomatic perimenopause. Some women don't have any symptoms, which is a really important message. I had a social media comment a couple months ago. It's still haunting me a little bit. She's like, I'm 48 and I feel great. I'm obviously in perimenopause because at that point, her cycles were starting to get further apart and irregular. And so I'm obviously in perimenopause, but I feel fine. I don't have any symptoms. Does that mean something's wrong with me? And I'm like, what is happening? Perimenopause is a normal transition. So the default should be symptomless. The fact that many women do experience symptoms is also real and is also needs to be talked about. But what's your experience as a psychologist and working with women and working in this space? Would you agree that the default for almost anything that's happening with women is, oh, there must be something wrong with me. Is there something wrong with me? Is my body broken in this regard? So even that, she felt fine, but she still thought that might be evidence that something was wrong with her. I think that's partly just because this really strong something with perimenopause out in the ether right now. If you're noticing things in your mid 40s, and there's a name for that, this is perimenopause. And now it's become, in the last just few years, like a very frightening something. Women being just very frightened and feeling very dark about this phase. I just want to contextualize it. The best analogy is puberty. Kids go through a tumultuous time in puberty, and you think, yeah, okay, that makes sense. Their brain is rewiring. Like perimenopause, our brain is literally rewiring. I have that chapter in my perimenopause book. So during a rewiring of the brain, which lots of times in a woman's life when that happens, actually, you can expect things to get a little glitchy. That's to be expected, really. But the analogy I give in my book is it's like a computer software update. It's like, it's do the little spinning thing. It's like update in progress. Do not turn off your computer. Just be very gentle with everything right now. But then once you're dated to the new software, it's like an upgrade. It's like, oh, I'm good now. And that's what the research shows too, is after the transition into menopause or postmenopause, whatever you want to call it, all the years that come later into women's 60s and 70s, the evidence is most women feel great. Their brains are fully online at that point and in their second spring, as some cultures call it.
Second spring. I love that.
Yeah.
I love that. So for women who, let's say they gather up their symptoms and they believe that they are in perimenopause and they go and see a doctor, can you explain a little bit about HRT? Because I think it's a little bit of a confusing space still.
Yeah. The first thing to say is it's not one thing. So HRT is not just one generic thing. It's in fact a lot of, and I'd be in that camp. I don't really love the term HRT because it's actually short for hormone replacement therapy. And replacement implies that this is a deficiency or a medical deficiency that needs replacing. And that's actually not the case. It's not analogous to like thyroid hormone replacement, for example, where you really do need thyroid hormone. Not that hormone therapy cannot be beneficial. So I've learned to preface this because I want to talk about some of the nuance, but I also know there's a lot of people who are really strongly in favor of hormone therapy. So I'll just preface it by saying I take hormone therapy myself. So I'm on a low dose of estrogen patch. I'm postmenopause for 4.5 years now. So I'm into that nice, stable 4.5 years past my final period. That's when things really start to settle down and feel good. But yeah, I'm on a low dose of estrogen patch plus body identical, what used to be called bioidentical progesterone. I do want to say it just so people will now listen to the rest of what I have to say. It's that, but that there's not like one size fits all like that. And so hormone therapy is a few different things for different situations. For example, I'll go through those different situations, but first I'll also say that hormone therapy really only works in conjunction with the other things. And a lot of these are pretty obvious things like quitting alcohol and moving the body. And these are all part of support for rewiring. In my perimenopause book, I call it rewiring the brain action plan. Like they're obvious things. Get sunlight in the morning for your circadian rhythm. The scientists who study circadian rhythm, if you read some of their papers, every cell in the body is on a body clock. And it's huge for neurotransmitters and sleep and everything. All these things you can do to support your brain rewiring, and then also consider some hormone therapy of different types, depending on what's required. And in the early phases of perimenopause, that would be in most cases, certainly with my patients and through the science of Geraldine Pryor, who I mentioned earlier, the endocrinologist, who's a scientist clinician, coming in with progesterone first. So body identical progesterone in Australia, that's available as Prometrium. In other countries, it's Utrogestin, or it's usually Prometrium or Utrogestin. There's a few other brand names as well of actual progesterone, not a progestin. So that can be very helpful. Geraldine Pryor just released a clinical trial where they found that progesterone alone, without estrogen, relieve the night sweats of perimenopause. Certainly it can be very good for mood, although sometimes progesterone's bad for mood. We can explore that a little bit. Usually good for mood. It promotes sleep. So all the things women are needing, the not sleeping, the feeling agitated, the heavy periods, the night sweats, that can all be improved with progesterone alone. And then as you move into the lower estrogen phases, and there's no blood test during that transition through perimenopause, when periods are coming closer together than normal, which is the classic part of the early phases of perimenopause, and heavier than normal, and there's breast pain, that's all evidence that estrogen is high, even though it's dipping to its normal low menopausal levels every cycle. And then obviously when you go 4 months between periods later in perimenopause, that's low estrogen. Your body's not making a lot of estrogen between periods like that. So that's when, usually a few years before the periods stop, when the periods get really far apart, for most of my patients, that's a logical time to bring in a bit of estrogen therapy and start low and titrate up. Because if you start too high, paradoxically, you can actually get symptoms of low estrogen from that. It just shuts the system down, overwhelms it. I'm in the camp where I think you kind of start low with estrogen and go up. And then if you then go through a phase where you're having close together periods again and super heavy periods and breast pain, which can happen, you've gone 6 months without a period and then you get a few right together, then you're back in high estrogen. You could just take a break from the patches again and come back to them. There's going to be some trial and error. That's just built into the process. There's no get on this and one size fits all. You can start and stop the hormones kind of as you need them. And obviously talk to your doctor about that process, but there's quite a bit of flexibility in that. And I would just contrast what I'm talking about, the human identical hormones that you would find in most modern hormone therapy, including the patches, the gels for estrogen, Prometrium for progesterone, Those are preferable. And those are very different from the progestins, from some older types of hormone therapy, and also all types of hormonal birth control are something totally different. And I just heard Geraldine say last week, and there's a few clips from the recording kicking around. I could probably direct some of your listeners to that interview we did with Geraldine last month, where she confirmed again the pill, like normal hormonal birth control, certainly the estrogen types, is not suitable during perimenopause. It just doesn't work very well at all. And it's not the body identical nice hormones. It's not going to have the good effect on mood. The exception to that would potentially be the hormonal IUD, which is obviously can be a lifesaver when it comes to super heavy flow. So I've written at length about that it's still not progesterone. The hormonal IUD is not progesterone. It's a progestin, which has different effects on the brain and can affect the brain in not a great way sometimes. But I say different effects than real progesterone on the brain, but it can lighten flow, which has a place. I'm sure some of your listeners know what I'm talking about. Like women in their 40s, the amount of menstrual fluid loss can just be like off the charts. And that's a sure way to guarantee iron deficiency, and then have iron deficiency be driving a lot of other symptoms.
When HRT kind of came out, which was a long time ago now, there was some research that came out that was probably, I think it was presented possibly in an incorrect way, that said that HRT was dangerous and increased your risk of cancer. But then it's been debunked now. Is HRT safe? I mean, you take it, so it's probably a silly question, because if it was proven not safe, you wouldn't take it. But where is that with the research now?
Yeah, really good question. You talk about the Women's Health Initiative study. I was around, I was a clinician at the time, so I've been practicing since the mid 90s. So I was definitely there. So my kind of trajectory was back in the late 90s. I was working in Canada then, but I was like pretty much full time, just switching everyone from the old school type of HRT onto what was called bioidentical then, trying to get them on the safer hormone therapy. I was just like 9 to 5. That was a lot of what I was doing, because that old school hormone therapy was not nice. And we knew it at the time. It was like watching a train wreck in slow motion. That's what I felt. Women didn't feel great. Anyway, that's a long time ago now. Then in 2001, they stopped a massive clinical trial because of increased rates of breast cancer in the hormone therapy arm of the trial, and also heart disease and some problems in the hormone therapy part of the trial. But it was a big data set. So depending on who's looking at it and what questions they're asking, one thing I think can say quite confidently that came out of that was that the breast cancer risk was from the progestin, probably not the estrogen. The estrogen they were using was Premarin, which is horse's urine extract. It does contain some body identical hormones, but it also contains a bunch of horse hormones. Like it's not the greatest. Obviously from the beginning, there's a whole, again, history lesson in that too, for anyone interested. And I just fact checked this. So the early makers of Premarin back in the 50s funded the early academic gynecology departments in the US. So Premarin was really deeply embedded in gynecology right from the beginning, which is a little bit interesting to think about the way estrogen has been positioned in all of this. But anyway, back to that study, the big takeaway, even in 2001, when the study results came out, and I was living in Sydney at the time, I'm like, wow, this is huge. This is interesting. This is like the nail in the coffin for progestins. I'm like, this is body identical progesterone. There's already a couple of trials at that time that body identical progesterone, or real progesterone prometrium, doesn't carry the breast cancer risk of progestins. I thought, this is it. I'm not going to have to do this job of trying to get everyone switched over to bioidentical. That's going to be the mainstream. It still took 15 years after that for that progestin part of it to get through. But as you know, the reaction to that 2001 results was that everyone just came off everything. I think the more logical response would have been everyone just switch over to body identical progesterone, but that's not what happened, unfortunately. So a lot of women went through, and we had a couple decades of women probably who needed some estrogen therapy, who weren't getting it. That's probably picking up on some of what you might have heard from other experts. I think that's definitely true. I think it's a good thing that there's been a bit more clarity now about that the body identical methods are safer, transdermal rather than oral. Estrogen is safer. Progesterone is safer. And I'll just point out, just to say again, progestins and their link with breast cancer, it's a slight risk, right? So I'm pretty confident in saying all progestins, including all the progestins in hormonal birth control, slightly increase the risk of breast cancer. But most women who take them will not get breast cancer. That's how risk works. But there is a slightly above baseline risk. And I guess the bigger story through all this is, why have progestins been so widely prescribed for so long? It's not just their effect on breast, it's their effect on brain health potentially and other things. This is now touching into a big part of my work has been finding alternatives for women, alternatives to hormonal birth control.
Okay. So what about women who are combining HRT with stimulant medication? Is there anything things to look out for there?
Yeah, good question. Again, it would depend on which type of hormone therapy, like just drilling down. Like my understanding is it's going to be a bit of a potentially additive effect with the estrogen component because estrogen is stimulating in itself and will enhance sensitivity to dopamine. Is that what you've heard from other experts?
I suppose one of the things in Australia that I find to be quite difficult, I'm not sure how it is in New Zealand, is that the psychiatrist is really in charge of the stimulant medication. He or she can pass back to the GP only when the person's stable. You may be able to change the dose slightly, but it's all very tightly controlled by the psychiatrist. But then what I find really difficult is that then another person will prescribe the HRT, and then you don't have somebody looking after both ends.
Sure.
And
Yeah.
then it's really up to the patient, I feel, to advocate for themselves, try and sort that out, because you have two practitioners or three that are all saying, I don't really know. There's nobody really overseeing the entire picture, is how I feel.
Yeah. Short answer, I'm not aware of a lot of research on that sort of medication combination, but just thinking physiologically what's happening, estrogen is going to have, it's stimulating. So estrogen is going to have an additive effect on that. So in theory, it depends on the person too. If their starting place was low estrogen, as in those later phases of perimenopause when there's not many periods anymore, and then taking an estrogen patch, for example, in theory, I could dial down the dose of the stimulant potentially. Someone being given estrogen when they're actually still in the high estrogen phase, where they're making up to 3 times higher, more estrogen than normal, that little bit of estrogen patch probably is not going to make much difference to the brain or to the interacting with the stimulant medication. And again, then there's progesterone. So if body identical prometrium progesterone is brought online, it's normally quite tranquilizing or sedating. So I would think that's like a good fit. So you take the stimulant medication in the morning and you take the progesterone at night for better sleep. But if you're taking a progestin, all bets are off because progestins potentially, well, they're known to create an abnormal stress response and increase anxiety depending on the progestin. There's like 20 different progestins. So you have to almost consider each one individually and what that might be doing to the brain. And then there's testosterone, which we haven't even touched on, which has quite a strong anti-anxiety effect, which could interact again. I think, isn't it true that even with the stimulant medication, it's not like there's like a one dose, you're like locked into one dose. Like you're going to have to titrate that up and down depending on, and maybe some days take breaks from it. And so there's an opportunity to check in with that and maybe try using less. And I would think it's that type of medication.
So a lot of women in Australia have got the experience of going to the GP and saying, I'm having all of these symptoms, and maybe they're brain fog, maybe they're ADHD symptoms, and the GP may or has, some of them will come back and go, ADHD is really overdiagnosed from TikTok or perimenopause. You're only 40, I don't think you're in menopause yet, and dismiss both of those and then offer antidepressants as you probably just got anxiety, it's mum life, that's hard, get more sleep, and give them an antidepressant. What would you say to women who are dismissed early? What can they actually do? If they're seeking help, they're not getting it.
Obviously, as a naturopath, I don't think an SSRI an antidepressant is going to be the solution for a lot of things. My solution is to do some kind of troubleshooting. So I would encourage people, probably one of my books, the starting place is Hormone Repair Manual, my perimenopause book. I think for even just the first couple chapters, someone will know if they're in perimenopause or not, because there's no test for it. It's pretty clear if that's what's happening. And then from that point, I start with some of the natural treatments, and don't underestimate them. Like some of those natural treatments for perimenopausal symptoms are heavy lifters. Like you can do a lot even before you get to hormone therapy, especially if you're advocating, if you decide, like after reading my book or listening to me today, that you want to try prometrium for especially those sort of earlier phases of perimenopause where cycles are still regular. I have various how to speak with your doctor sections in the book. One of the simplest ways to get a prescription for prometrium, and this is an honest way, it's not like being tricky or anything, focus it on the heavy periods, especially if there are heavy periods. Just say, I'd like to try prometrium to lighten my flow. And you can say, I understand it's safer than a progestin, which is true for breasts. And the whole part that progesterone is also going to help with my brain and help me sleep and potentially help with my ADHD. You don't have to go into all that with the doctor. Doctors don't have a lot of time. In my writing and into my advocating, or keep it really simple with the doctor. If you can boil it down to a simple reason why you want to try a medication like prometrium, just keep it simple. The doctor doesn't have to be fully on board that it's going to help with perimenopause or ADHD symptoms. They just have to be like, okay, it will lighten your flow. They're going to know that's the case. So it keeps it a little easier. And also sometimes things can be presented as, I would like to try this for a few months because I understand it's safe to try. And through that lens too, the doctor doesn't have to fully agree with the full self-assessment, or they just agree that a particular medication is worth trying. And another thing I want to say about, because what you just said in that scenario there, we go to the doctor and say, I'm in perimenopause. And then like, oh no, your menopause isn't for years. This is a perfect example. There's been one of the things that's been happening in the perimenopause space, which is really unfortunate. It's not unique. It happens in other areas as well, but this conflation of the two words perimenopause and menopause, entirely different thing. The perimenopause is the anywhere up to 10 years before the 1 year after the final period. It's the time of turbulence and change and neurological symptoms, if there are going to be neurological symptoms. Menopause, depending on how you define it, or postmenopause, is that kind of what Geraldine talks about, the life phase that begins 1 year after your final period. So I would say I'm in menopause now, like I'm at 5 years after my last period. But part of the confusion is, especially out of the UK, it affects us here in Australia and New Zealand as well. There's also the phrase the menopause transition, or the menopause, just gets shortened to the menopause. That's actually synonymous with perimenopause. So then you get, well, menopause is associated with all this neurological transition and turbulence, but that's actually perimenopause. So I think it's just the simplest is just if there's neurological symptoms, it's perimenopause.
Yeah, have a 15-minute appointment with a doctor and debate whether you're in perimenopause or menopause or postmenopause.
No.
Like at that point, I agree with you. Just go with your core issue and keep it really simple for them.
You don't even honestly have to name perimenopause with the doctor. You could just say, if periods are heavy, that's an in for progesterone. That's a totally legitimate reason for them to prescribe progesterone. Another legitimate reason could be sleep. So it's very sedating. So you could say, I'm 45, obviously I'm coming up to menopause, if you want to phrase it. My understanding, this clinical trial here, and there's a reference in my book, progesterone helps sleep and is safe to take for sleep. And so that kind of thing, as you just focus it on the main symptom.
Okay. So as we come to a close, what would be a core message that you'd like to share with an ADHD woman who might be coming up to those phases? Do you have kind of something that you come back to that you've learned?
One really important thing about perimenopause is it's temporary. So the transition, the neurological turbulence, rewiring is temporary. And it's just a really important thing to get your head around. So there's this beautiful quote from Professor Geraldine Pryor. She says, women need to know that the turbulent time of perimenopause ends in the kinder and calmer phase of life called menopause. Once you get to the late 50s, things get a lot better and cruisier. And that's whether you take hormone therapy or not. Like even the hormone therapy doesn't totally dampen the turbulent times of perimenopause. And it is true that there's some research that for some women, and it's not the majority, a difficult perimenopause can be a tipping point into longer term mental health and cognitive decline problems. That's in the research. So that's important to know about. It's good that research is being done. And that's why it's such an important opportunity to say to my patients, if there was ever a time to prioritize health, it's in your 40s for women. It's this tipping point or this crossroads where you're going to go down the path to long-term health, another few decades of good health, or you're going to go down the wrong road. I think that's just a really important takeaway message. And if the night sweats, the migraines, the anxiety, the intense premenstrual, obviously that's not going to last forever. And it doesn't mean you just endure it. Obviously you do things to feel better, but you also understand that your brain is you're going to pop out the other side feeling good. And I just think that's my takeaway message, because it's so much of this has been pathologized and overly medicalized, and it's second puberty. So it's a time of transition. And also the other takeaway is most of the time, I understand there's always outliers. I always get the people saying, oh, but I'm different. But my experience is for most women, even women with an ADHD diagnosis, like pretty simple things can really move the needle on feeling better. I'll just give a plug again for circadian rhythm. That like getting outside in the morning and getting outdoor light is huge. The brain loves it. Some people talk about light nutrition for the brain, like that outdoor light is huge, especially timed into the morning. I would just give a plug for quitting alcohol. Alcohol is so unfriendly to the rewiring that has to happen during this phase. And also just say, take magnesium. Anyone who's read my books know that I'm a huge fan of magnesium. It's really good for neurotransmitter balance in general, almost which direction it's going. I'll also just point out for ADHD in particular and histamine issues, carefully used vitamin B6 can be a game changer as well. It increases dopamine, increases GABA, and it lowers histamine. So it's this like multi-tool But the thing about B6, it's been on some of our radar for a while. You do have to be a little careful with the dose. Too much can cause nerve damage. That's been in the news a bit lately. But so if anyone has a nutritionist or a clinician they can work with, what I tend to do is just not high dose, but slightly higher dose B6, just during the premenstrual phase, like during the really bad kind of time, and then back off it at the end, just so you don't risk taking too much. There's no kind of one amount of B6 that's safe for everybody. It varies. But going back, whatever it is now, 30 years to when I first trained as a naturopathic doctor, I remember then being prescribed, like in the student clinic, vitamin B6 for PMS, premenstrual. And I was just like, what is this magical? Was that effective back then? And like, in 30 years on, it still works. So I'm not saying everyone has to take that. I'm just giving it as some examples of safe things. And also magnesium and B6 are safe with stimulant medication. Of course, check with your pharmacist anytime you take anything and combine it with medication, you want to check, but they're pretty straightforward, kind of simple approaches.
Thank you so much for your time. If there's anyone who listened to this interview, I'm sure there'll be a lot of people that would want to have a look at your book. I can put that in the show notes. Is there any recommendations on like how they can work with you or anything possibly to read? Anything that you'd like to talk about as a general good education?
Oh, yeah, Jane. Yeah, thanks for having me. It was great to chat with you. No, I think for this audience today, my main resource is Hormone Repair Manual. It's my perimenopause book. I do see patients, but face-to-face in Christchurch. So I guess if you have any Christchurch listeners, they could get on my wait list for that. Otherwise, yeah, I've got all my social media is at Lara Briden. I'm pretty easy to find. I've got blog posts and a solo podcast episode on PMDD. So we didn't really dig down into the full PMS versus PMDD, but I've written about that quite a lot. So people can check that out. Especially I've written a bit more about the histamine side of premenstrual mood symptoms.
Thank you so much for your time. This has been really enlightening and I'm like fully in a rabbit hole in my mind. So thank you so much. Quick announcement. Did you know that we have an ADHD Mums shop filled with resources designed just for you? These resources are packed with answers to the most frequently asked questions I get sent in via email. Everything from understanding ADHD and autism to practical tips for daily life. There's also a free assessment tool. If you're wondering about ADHD or autism for yourself or your little one, don't forget to check out the free assessment tool under free resources section on my website, adhdmums.com.au.